Welcome to our first video on intracranial hemorrhage. Let's begin. Here's an overview of what we'll discuss in this lecture. Let's begin with subdural hematoma. We'll go over the definition, etiology, pathophysiology, clinical presentation, diagnosis, and management of subdural hematoma. A subdural hematoma is defined as a collection of blood between the dura mater and the arachnoid mater. It can be acute or chronic. Here's an illustration showing the subdural hematoma. We can see that the blood accumulated deep in the dura mater and superficial to the arachnoid mater. Let's talk about etiology. Head trauma is the most common cause. In fact, subdural hematoma is common among elderly patients who recurrently fall and hit their head. Anticoagulation is another contributing factor, and since many elderly patients are on anticoagulant drugs, they are especially at risk. Cerebral atrophy, which is often seen in elderly patients as well, can increase the risk of developing a subdural hematoma. Subdural hematomas may be seen in the context of child abuse, typically as a manifestation of shaken baby syndrome. Therefore, if brain imaging in a young child reveals subdural hematoma, the clinician should suspect that the child is being abused by their caregiver. Subdural hematomas are typically caused by tearing of the bridging veins in the subdural space. This results in extravasation of blood at a relatively slow rate. The bleeding may cross the cranial suture lines. However, it cannot cross the midline because the subdural space is fixed to the falx cerebri. This illustration shows the bridging veins. Bridging veins are located in subarachnoid space but go through the dura mater and empty blood into the dural venous sinuses. They are typically ruptured in the subdural hemorrhage. Patients with a subdural hematoma will often report a history of head trauma several days or weeks before presentation. When the hematoma expands, the accumulated blood compresses areas of the brain, leading to lethargy, confusion, impaired consciousness, and focal neurologic deficits such as hemiparesis. When subdural hematoma is suspected, the best initial test is obtaining a non-contrast CT of the head. The bleeding will typically be detected as a crescent-shaped lesion that can cross suture lines. The signal intensity can give us an idea of how old the bleeding is. Acute bleeding appears hyperdense or light in a non-contrast CT, while chronic bleeding appears hypodense or dark. These CT scans provide a great example of an acute subdural hematoma compared to a chronic one. Notice that the bleeding appears crescent-shaped in either way. When the hematoma appears white or hyperdense, it is acute. If it appears dark or hypodense, then it is chronic. Let's discuss management. Small subdural hematomas can regress spontaneously. However, the surgeon may choose to evacuate the hematoma if it is severe. Some of the criteria of a severe hematoma includes one that is 10 millimeters or greater in size, one that is causing brain herniation, indicated by more than 5 millimeter midline shift, one that causes neurological deterioration, or one that has failed conservative management. A 70-year-old woman is brought to the physician due to excessive sleepiness for the past month. She has a past medical history of chronic alcoholism and frequent falls due to alcohol intoxication. Her serum TSH level is normal and depression screening questionnaire is unremarkable. The physical exam reveals right hemiparesis, which was absent on the last checkup. What is the best next step in the diagnosis of this patient? This elderly woman presents with excessive sleepiness for the past month. She has a past medical history of chronic alcoholism and frequent falls due to alcohol intoxication. Her serum TSH level is normal and depression screening questionnaire is unremarkable, making underlying hypothyroidism and depression unlikely. The physical exam reveals right hemiparesis, which was absent on the last checkup. Sleepiness and the new onset of focal neurological deficits in a patient with frequent falls raises suspicion for subdural hematoma. The best next step in diagnosis of this patient with suspected subdural hematoma is non-contrast head CT scan. Let's move on to discuss epidural hematomas. We'll discuss the definition, etiology, pathophysiology, clinical presentation, diagnosis, and management of epidural hematoma. An epidural hematoma is defined as collection of blood between the dura mater and the periosteum of the skull. Here's an illustration depicting the layers that are involved in epidural hematoma. The bleeding occurs superficial to the dura, which I am labeling here, and deep to the periosteum, which I am labeling here. Most epidural hematomas are caused by severe acute trauma to the head, for example, motor vehicle accidents. Occasionally, they can be caused by non-traumatic conditions such as coagulopathies, malignancies, and vascular malformations. As mentioned previously, severe head trauma is the most common cause of epidural hemorrhage, and it typically affects the terion. The terion is the suture where several skull bones come together, and it is a weak point in the skull. We see an illustration of this in a moment. The trauma causes tearing of the middle meningeal artery, which leads to bleeding into the epidural space. In this illustration, we can see where the terion is. Notice the relationship between the terion and the middle meningeal artery, which is seen here. A trauma involving the terion will lead to tearing of this artery and epidural hemorrhage. Let's discuss the clinical features. Patients typically present with a history of head trauma that occurred minutes to hours before presentation. One high-yield point to remember about the clinical presentation of epidural hematoma is that it commonly involves a lucid interval. This means that after the head trauma, patient will have a brief loss of consciousness, then regain consciousness and feel relatively fine for a short period of time, but later develop deterioration of neurologic functions. Also, bleeding into the epidural space compresses the brain and leads to high intracranial pressure with possible brain herniation. Two common signs of brain herniation include an ipsilateral dilated pupil with contralateral hemiparesis. When epidural hematoma is suspected, the best initial test is a non-contrast CT of the head. The typical finding is a lens-shaped or biconvex hyperdensity that does not cross the suture lines. There may also be an evidence of skull fracture present in the trauma area. This is a CT scan of an epidural hematoma. Notice the lens-shaped lesion that does not cross suture lines. It appears white or hyperdense, indicating that the bleeding is acute. An epidural hematoma is treated with an emergent burr hole craniotomy and ligation of the bleeding artery. Introducing a burr hole allows drainage of blood, relieving the high intracranial pressure and prevents brain herniation, which is the main cause of death in patients. A 17-year-old man is brought to the emergency department unresponsive after being involved in an altercation. Friends report that he was hit on the left side of his head by a baseball bat. After initial loss of consciousness, the patient recovered for several minutes. However, he lost consciousness again in the ambulance car. The physical exam reveals dilated left pupil. What findings are expected on a non-contrast head CT scan of this patient? This young man is brought unresponsive after being involved in an altercation. He was hit on the left side of his head by a baseball bat. After initial loss of consciousness, the patient recovered for several minutes. However, he lost consciousness again in the ambulance car. This phenomenon is known as lucid interval. The physical exam reveals dilated left pupil, indicating the imminent risk of brain herniation. The lucid interval and focal neurologic deficits after head trauma raise a strong suspicion for epidural hematoma. A non-contrast head CT scan in the patient with epidural hematoma typically shows the lens-shaped hyperdensity that does not cross the suture lines. Let's end this lecture with a board-style question. A 77-year-old female presents to the ER due to recent onset of lethargy and confusion. While performing a physical exam, the patient appears to be slipping in and out of consciousness. Her daughter is with her and mentions a minor fall about a week ago, but the patient had seemed fine until now. A non-contrast head CT is ordered to get a closer look at what is going on with the patient. Results show a crescent-shaped lesion that does cross suture lines, but not the midline. What is the pathophysiology behind this patient's current presentation? A. Tearing of bridging veins. B. Severe head trauma. C. Ruptured aneurysm. Or D. Hypertension. This 77-year-old woman presents with lethargy, confusion, and loss of consciousness. Additional history reveals a minor fall about a week ago. Non-contrast head CT shows a crescent-shaped lesion which crosses suture lines but not the midline. Based on the patient's head CT, she has a subdural hematoma, which is often caused by tearing of the bridging veins during a minor fall in a patient with cerebral atrophy, such as an elderly patient. Therefore, answer choice A is correct. Answer choice B is incorrect because severe head trauma is the typical cause of an epidural hematoma, which looks lens-shaped on CT and does not cross suture lines. Answer choice C is incorrect because a ruptured aneurysm is the typical cause of a subarachnoid hemorrhage, which often presents as an acute onset of the worst headache of a patient's life. Answer choice D is incorrect because hypertension is the typical cause of an intraparenchymal hemorrhage, which often results in ischemia to the basal ganglia. And that concludes this section.